Welcome to everybody in the room. Thank you so much for coming. We're thrilled to see such a strong turnout tonight. We know how important it is for every community to have access to high quality, affordable health care, and we appreciate you joining our conversation tonight. My name is Jessica Holmes, and I'm a member of the Green Mountain Care Board. I am joined by Brendan Krause from the Agency of Human Services, Mike Fisher from the Healthcare Advocate, and there's a group of Green Mountain Care staff here, Green Mountain Care Board staff here, who have worked tirelessly to manage all of these meetings across all of these communities in Vermont. So it's really appreciate all the work that they've done. It's great to see some legislators here, so thank you for coming as well. And I want to offer a special shout out to Tracy Moore, who has been incredible. I don't know where you are, Tracy. Oh, she's out there coordinating, maybe. Where are you, Tracy? Are you? Oh, no, you are here. Sorry. Anyway, you've been so helpful in helping to facilitate this venue, and we really appreciate that. So I wanted to give that shout out. A couple logistics. There's some refreshments back there. Probably most of you know this, but the bathrooms are out there to the right. That's where the exit is. Closed captioning is available. There's a QR code up here. If you want to use that. Also, there's some people in the room who can help you if anybody needs help. Daniel, if you could raise your hand. There's Daniel. Daniel can help you if you need some help getting the closed captioning. There's media local access TV here, so I wanted to let everybody know it's being recorded. We will have Q&A and comments at the end of Dr. Hammery's presentation, which I know you're all here for. We ask that you limit your comments to about a minute. Or questions to a minute. There's a lot of people here. We want to make sure that people have time to ask their questions. If you have longer prepared comments, we would appreciate if you would send them to the Green Mountain Care Board public comment portal. I promise you we read all of the comments, so that would be really helpful. I just wanted to open up with a couple of remarks about what's really bringing us all here together today. So for years, I can tell you at the Green Mountain Care Board, but everybody in communities have heard that healthcare in Vermont is becoming unaffordable. Employers, patients, and families are facing skyrocketing healthcare costs and skyrocketing insurance premiums. We've also seen how rising healthcare prices can impact education taxes and property taxes. Over the past year at Green Mountain Care Board meetings and in our listening sessions with communities, we've heard heartbreaking stories of patients who are choosing basically between filling their prescriptions and paying their rent. We've heard how healthcare premiums are crippling small business owners trying to provide health insurance for their staff. And last week at a public forum, we heard from mental health therapists who are struggling to pay for their own health care. And yet, despite paying more and more for healthcare, we also hear that people cannot access the care that they need when they need it. A little anecdote, yesterday or 2 days ago, I spent 45 minutes on hold trying to schedule an appointment for a medical procedure, then to be told that I had to call back in 3 weeks when the November schedule was available. So I feel the pain of the frustration of not being able to schedule your care. We know that many primary care practices are closed to new patients, and we know that people are waiting months to see specialists. We actually received public comment from somebody in this community today about access challenges. So it's real, and we have to start to manage how we're going to manage the access problems. As many of you also saw in recent headlines, our local nonprofit insurance companies are also struggling. Their dwindling reserves now are putting them at risk of being unable to pay for our medical claims. Our providers are also struggling. We hear from Vermont's independent providers that they cannot afford to practice in Vermont anymore. They're not earning enough to be able to recruit and retain needed staff. And as I mentioned earlier, some are even struggling to pay for their own health care. And our hospitals are not immune to these financial headwinds. In 2023, 9 of our 14 hospitals were in the red. This is especially troubling given that in that year, the Green Mountain Care Board allowed many hospitals double-digit price increases to keep them afloat. Vermont is not alone in facing these challenges. Rural hospitals nationwide are losing money, they're cutting services, and they're closing at alarming rates. They're thrusting the communities that they serve into crisis. And we've seen that market forces left to their own lead to the abrupt loss of healthcare services in our most vulnerable rural communities. The Green Mountain Care Board and AHS, we do not want that to happen to any community in Vermont. But as Vermont's working age population shrinks, and its population ages, reimbursements are not covering the cost of delivering care to our communities. Our healthcare system is at an inflection point, and we must make significant changes now. We're here to learn about possible paths forward from Dr. Bruce Hammery and his team at Oliver Wyman. You may not know Dr. Hammery yet, but you're likely familiar with his work. Dr. Hammery is an infectious disease doctor who helped the state with its COVID modeling during the pandemic. He is a former chief medical officer at Geisinger, which is one of the most well-respected healthcare systems in the country. And lucky for us, he's also a health systems design expert who's been consulting hospitals and health systems for many, many years. He and his team have reviewed data. They've reviewed state reports, consultants' reports, population projections. They've held over 100 stakeholder meetings and listening sessions, and they've visited every hospital in the state, trying to help us figure out whether our healthcare system is able to serve Vermonters' needs now and in the next 10 years. Dr. Hammery's presentation will be a critical first step in a much longer process. The legislature has directed the Agency of Human Services to lead the next stage of system transformation by working with hospital leaders and communities to find a more sustainable path. So with that in mind, I'm actually going to pass it over to my colleague, Brendan Krause, from the Agency of Human Services for a few remarks.
Thank you, Jess. Hi, I'm Brendan Krause, the new Director of Healthcare Reform for the Department, for the Agency of Human Services. This is my 4th week, so I think I have another week of being able to call myself new, and after that, it's probably, I'm fair game. So thank you for having me tonight, thank you for coming tonight. Thank you to the legislators for being here, and to Dr. Hammery. I'm not going to repeat the problems and the challenges and opportunities that Jessica did, because as you're about to find out, this presentation is very, very thoughtful and dense, so there's a lot to get through. But I just reiterate that this is the beginning of a longer process. We will be working with our colleagues at the Green Mountain Care Board and others to take some of the recommendations that Dr. Hammery and his team have made, work with hospitals to sort of understand the impact that those might have in a community, how much they would cost, what the results would be, and begin to prioritize some of those, and then come back to the communities themselves to understand what is the best use of resource. And then we will continue to support that transformation on the ground as communities and leaders decide what is right for them. So with that, I will say thank you very much and hand the mic to your CEO, Judy Fox.
Thank you for being here. Fox, and I have the great privilege and honor to represent Rutland Regional Medical Center as their CEO. I too would like to welcome you to this evening's community forum. I'd like to thank the members of the Green Mountain Care Board, the Agency of Human Services, and the team at Oliver Wyman for spearheading the efforts to help Vermont's hospital leaders understand and solve for the critical issues that Vermonters face as they seek healthcare services. The strength of our hospital is critically important to our region and has been for more than 125 years. Our community relies on us not only for accessible, high-quality care, but also as a solid community partner that supports the vibrancy and the economy of our region. Last fall, Rutland Regional launched planning efforts to evaluate strengths, weaknesses, opportunities, and threats that impact our ability to provide timely, high-quality, and affordable care, and to ensure that we remain as a financially viable community partner. As part of our planning process, our board and staff reviewed state and national healthcare trends that focused on culture, workforce, access, and affordability. No doubt, some of the same information that Oliver Wyman used in their study. This work helped to shape a renewed organizational mission and vision and allowed us to prioritize strategies on how Rutland Regional can continue to thrive to meet our mission, to provide high-quality hospital and specialty care for all through the strength and compassion of our people. Rutland, like many rural communities, faces ongoing challenges: an aging population, increased substance misuse and addiction, mental health issues, transportation, lack of post-acute care options, ongoing homelessness, inadequate housing, and workforce shortages. The challenges and opportunities that Dr. Hammery will describe to you this evening are very much aligned with the challenges and opportunities that our leadership team identified. While there are several initiatives that Rutland Regional must lead and drive, there are also others that require state and federal partners to help resolve. Rutland Regional stands ready to be a committed partner to solve these difficult challenges. Collaboration is necessary to ensure that we minimize waste in healthcare, and there is waste in healthcare. We commit to work together with state and local and federal partners to build our healthcare infrastructure to allow for the right care in the right setting. We are focused on minimizing care that is inappropriate for hospital settings, while at the same time increasing access to care for acute inpatient, ancillary, testing, and specialty care that is appropriate and should be expected for hospitals to deliver. So thank you again. Now I'll hand it over to Dr. Hammery.
Thank you very much. Thank you all for coming. It's an important conversation that we want to have, and certainly to hear from you about some of the issues and potential solutions that I want to present. So we're here this evening to report to you in the Rutland community on our efforts to fulfill the mandates of Act 167. These are to conduct a data-driven, patient-focused, community-inclusive effort to assist Vermont hospitals in reducing inefficiencies, lowering or constraining cost growth, improving population outcomes, reducing health inequities, and increasing access to essential services. Our Oliver Wyman team is here to present and answer your questions along with the other people and groups present. My name is Bruce Hammery. I am a physician with over 50 years of experience in practicing and teaching medicine in hospital and health system administration and in healthcare consulting. My partner in this effort is Ms. Elizabeth Sutherland, a partner in the firm of West Monroe and an expert in health inequities. We've been ably assisted by Ms. Irene Way, who's here tonight, our engagement manager, and Ms. Melissa Kowalski. My team and I began this journey to evaluate the health system and hospitals in Vermont 11 months ago in August of 2023, so it'll be a year tomorrow. We have spoken with and listened to over 2,000 Vermonters from all 14 hospitals across the state. In this journey, we have been greatly assisted by the staff of the Green Mountain Care Board, Ms. Marissa Melamed, Mrs. Hillary Watson, and many others. We have also been helped by many leaders and staff throughout the Agency of Human Services and by Mr. Mike Fisher and his staff at the Office of the Healthcare Advocate. Mr. Mike Del Trecco and his staff at the Vermont Association of Hospitals and Health Systems have also been especially helpful. Another consulting firm, Mathematica, and a team led by Dr. Arkadipta Ghosh have performed many of the data analyses we have used to develop options for changes in care delivery in the state. These have been presented to each hospital and its board. Those options were then amended based on our conversations with that hospital and its board. So why are we here today? We want to accomplish 4 things. 1, to report back to you what you and other Vermonters have told us about your lived experience with healthcare. 2nd, to explain the problems facing your hospital, your community, and the state as a whole. Most of these issues are beyond the control of the hospital, as Ms. Fox has mentioned. We will also show you what some of these impacts may be on your community and on the Vermont health system. 3rd, to share at a high level what some options are that could be used to address the current and future projected needs. These will apply to most hospital communities, but not necessarily to this one. I would also comment that we have an extensive list of options and recommendations. I've presented some of these in previous meetings with the Green Mountain Care Board, June 19th and July 9th. Those slides are available for you to look at. We will not have sufficient time tonight to go into a lot of detail. And so while I can assure you that we have been looking at things to do with primary care and mental health and substance abuse and homelessness and a number of other issues, we don't have 2 days. So I appreciate your questions on those, but just know that there are a number of things that we are concerned about, have talked to people about, but will not have time to go into tonight. Fourth, and most importantly, we want to set the stage for your active participation as a citizen and as a community in this process to transform healthcare in Vermont. This will be led by the Agency of Human Services and supported by the Green Mountain Care Board. And as you've heard, this is the next step in fulfilling the mandates of Act 167. So these quotes represent part of what you told us when we met electronically in late October. The Community Health Center has an enormous waiting list for mental health services. The first thing you hear when you call the hospital is if you don't speak English, press 2. People can't get past that. I would note the legislature has had some legislation passed to deal with bills and signs in hospitals in multiple languages. This is an issue I think that I've seen still on some websites and some of the phone trees that will still need to be addressed. The lack of housing is a problem, making it hard to attract providers. We'll come back to this. A lot of times the prior authorization process has a mandatory 2-week waiting before we're able to do anything and before they even give us an answer. Again, the legislature has recently passed some legislation that deals with this. Transportation to and from all care is an issue. We'll talk more about this. And the longevity of providers that are hired by community health is very short. They tend to move to private practice very quickly because compensation is not adequate. So these are some comments from around the state. You see the lack of housing, you see the transportation, workforce shortages. Many individuals don't go to care because the premiums and out-of-pockets are too high. No one tells patients about financial services or campaigns available to support their broader health and social needs. So, and I'll note, I can no longer afford the procedures or medications. My only option is not to take my medication. Gender affirming and reproductive health access is an issue, and there needs to be greater availability. So just a sample, and very common problems across the state. And many of these are equity issues: housing, transportation, affordability, language, gender issues, and others. So let's set the background for your current experiences of healthcare in Vermont. As noted, all Vermont communities are facing significant challenges in healthcare access, equity, and affordability. The access and equity challenges, or some of them, are shown on the left, the affordability challenges on the right. Note difficulty in getting timely appointments for doctors and for surgery. You've experienced that, you've heard about it tonight. Transportation to and from appointments, to and from the pharmacy, particularly for urgent care issues when you can't schedule 48 hours ahead, is an issue. Transportation to the hospital emergency room, and from the hospital emergency room to either wherever the patient needs to go and from the hospital then to the nursing home or another hospital are also issues. Excuse me. On the affordability front, there have been major increases in both health insurance premiums and out-of-pocket expenses, making the use of health care out of financial reach even for people with good insurance. And we'll come back to that. Major changes are needed to reduce these issues and slow these rates of increase. Vermont hospitals and many others in the U.S. are facing significant operational and financial challenges. As was noted, since 2005, there have been over 200 closures of rural hospitals in the U.S. 12 have closed in the last 6 months. So it is a major issue for all rural hospitals. There are said to be another 600 that are in significant danger of closing. So these challenges include the inability to recruit staff, whether that is due to a national shortage of physicians, nurses, or other professionals, or to a lack of affordable housing in Vermont when they can be identified. So I've heard a number of stories from hospital folk and others around the state that they've been successful at recruiting a doctor or a lab tech or a nurse or somebody. Those folk have come to work, they've spent 3 months in a hotel, and they leave. And so housing is an issue not only for the unhoused or those living in inadequate housing who live in Vermont, but also a problem in recruiting everybody, not only health professionals, but clearly workers in many other industries. Another major issue affecting small communities is the number of doctors in a specialty that must be recruited to provide an acceptable call schedule. Call schedule is how many nights in a week are you on call for either taking patient issues or going to the hospital. The community must also have enough patients to support that many doctors. 40 years ago, when I trained, or a little after, an acceptable call schedule was 1 night in 2. Now it is 1 night in every 4 or 5. So this presents recruiting difficulties across the U.S., not only for small hospitals, but also the larger academic centers, because you really need enough business, enough people who need that service to support that many folk, and the staff that they need to do whatever they do, and the equipment. Many hospitals are old and need to replace air conditioning, heating units, elevators, and so forth, and they've not been able to make the needed money from their patient revenues. Some surgeries done at hospitals are done too infrequently for the staff to maintain an adequate proficiency. Many of these require not only expertise on the part of the surgeon, but also from the anesthesiologist, the operating room staff, and often support from an ICU or certain specialists. Supporting these teams with the staff and equipment necessary will likely require hospitals to combine some surgical and medical specialists in ways that permit regional access without requiring people to travel either to Burlington, Dartmouth, Albany, Boston, or wherever. Many hospital resources are also consumed by people who do not need the services of an acute care hospital. These individuals may be waiting for transfer to a mental health facility or chronic care facility. They may need a place to live or the services of a home health agency to be discharged from the hospital or the emergency department. The hospital is not paid for these patients as their care is, quote, no longer medically necessary. They also occupy beds and nursing time that could be used for other patients who do require care in an acute care setting. On the financial side, the costs of the people who work in hospitals and the supplies and the supplies that are needed to care for patients are increasing at rates higher than the rates the hospital is paid. There have also been 4 unanticipated changes in federal policies within the last 6 weeks that will increase the cost of health care or potentially reduce access. First, an imposition of a tariff on all medical products produced in China. This tariff will go from 0 now to 7.5% in 2025 to 25% in 2026. So the hospital will be paying more for gloves and bandages and all that. I will note that one of the presidential candidates has proposed a tariff on everything not made in the U.S. Many of our drugs come from India. Many of our high-end medical things, the CT scanners and this and that, come from Germany. So were those things to go into place, another set of increases would occur. Second, there is a requirement, an appropriate one needed to improve quality, to staff skilled nursing facilities with more RNs. So this is a group in short supply. So again, needed, but it will make folks potentially shorter. Wages and benefits, by the way, account for roughly 60% of total hospital costs. So it's predominantly a people expense and then supplies. Third, there's been a cut proposed in Medicare payments to doctors of 3.5%. So if the hospital employs doctors, that's going to have a decrease in income. For people in private practice, of course, it makes life more difficult. Fourth, the Congress recently passed a law cutting payments to home health agencies by 7.5%. Now, in my opinion, at least, this represents taking a meat cleaver to a problem. The issue that they were addressing is that for-profit home health agencies make a lot of money. But they didn't exempt not-for-profit home VNA and other home health agencies. So they've been having problems affording nursing staff, and this is going to make their life more difficult as well, and therefore likely back up people into the hospital because they need home-based care to get home. As Dr. Holmes noted, in fiscal year 2023, 9 of the 14 hospitals in Vermont had negative operating margins. An operating margin is like the balance in your checking account. It reflects the income from patient services minus the expense of providing those services. If you include the 2 additional Vermont hospitals in the red, in fiscal year 2022, 11 of the 14 hospitals in the state have had negative operating margins in the past 2 years. This makes borrowing money expensive and difficult for the hospital and makes the financial sustainability of the hospital problematic. I must note that Ms. Fox and her staff, and in fact all hospital directors and their staffs and their nursing people and everybody, are working very hard to address these cost issues. Not-for-profit health plans in Vermont are also not making money, and we'll get back to that in a few minutes. So, as you've experienced, every commercially insured Vermonter's cost for health care has increased markedly over the past 6 years. As shown on the left here, between 2018 and 2022, the median increase in household income for Vermonters was 22%. In the middle panel, the Green Mountain Care Board approved hospital-requested increases in charges of 38% over that period of time. On the right is shown a benchmark plan from Blue Cross, which has increased 108%, so it's doubled, And as you see the dark line below, that's the cost in Massachusetts. And so what you notice is in 2018, those were within $18 of one another, and now Vermont is twice as expensive. So you can see the trickle up. So steps must be taken, plans must be made and implemented to change these rates of increase. So how are we approaching this? Well, I'm a doctor, so we took the approach any doctor would take for a sick patient. We used interviews and data to make a diagnosis. We used tools and data to make a prognosis, a forecast of what the future might look like given certain assumptions, and I'll go through those with you in a minute. And we developed and identified a number of treatment options. Some were drastic, and all may require substantial changes. You, as the patient, get to make the choice of treatment together with the hospital board, other communities, and hospitals, the Agency of Human Services, the Green Mountain Care Board, and others. So we listened to you and other communities. We took a history of your present and past illnesses, reviewed your symptoms, and so forth. This slide's a little out of date. Including these community meetings we've held in July, we've spoken to a little over 2,200 folk and heard their comments. And you see the numbers of different groups that we've spoken with. These have included not only hospital leaders and boards, but also the many healthcare professionals who serve you. These include dentists, physical therapists, mental health counselors, doctors, nurses, pharmacists, EMTs, home health agencies, nursing home administrators, and many others. We have spoken with many state agencies and departments as well as legislators. We have also met with a number of community and state organizations advocating for those who suffer from health inequity and those with special needs, whether those are mental health needs, physical needs, or with specific illnesses needing more specialized care. We have sought out groups with unique language, ethnic, and gender identity characteristics. We performed tests on your community. Mathematica did projections of total population in the Rutland area, and Ms. Fox has alluded to these. I want to call your attention to a couple of things. This shows an estimate that over the next 10 to 15 years, your population will shrink by about 15%, drop from roughly 61,000 down to almost 52,000. Now, there are a couple of important parts to this. One is those top blue sections on this. So if you note, the group called aged is 65 to 74 years. I consider those young people. And that group is going to just about double. That's going to go from 13% of the population to almost 26%. The other group, the dark blue group, is the advanced elderly. I'm one of those. And that group's going to increase slightly, but from 8% to almost 12%, so about 50%. But what I want you to notice is in 2040, combined, that group is 37%, which means that more than 1 out of 3 people who live in this county are going to be over 65. And those folks have markedly different needs than working age folk. And they're going to need more long-term care. They're going to need memory care. They're going to need assisted living facilities. They're going to need support to, quote, age at home. And the Agency of Human Services has a group that works on that and makes some of that available. They're going to need more physician visits. The average number of physician visits for a person between Age 3 and age 64 is about 3 a year. The average number of primary care physician visits for a person over 65 is almost 11. The other thing I want to call your attention to is that dark gray bar. That's the number of working age people, ages 20 to 64, who can buy, if they can afford it, commercial insurance. And what I want you to note is that group drops from 56% of the population down to 43%. So that's a difference of about 1/3. It's a huge drop. And what it means is that, the insurance premiums, which have been going up, produce a certain amount of dollars. And if you have 1/3 fewer people that you need to generate that same number of dollars from, those rates are going to be much higher. Okay, that's not an affordable thing. We also use this to estimate numbers of cancer, hospitalizations for heart disease, stroke, and that kind of thing. I shared that with Ms. Fox and her board for their planning purposes. So that's a real tsunami that's coming. It is common across the state except in Burlington and Chittenden County. They see an increase in the population, but still a large increase in the number of elderly. Okay, and if I remember correctly, that number's somewhere around 35,000. So it's big. It's a big number. It's not, as high a proportion. Okay. So we did a physical exam to look at the systems of care. This project blossomed from just hospitals to the recognition that hospitals don't control who comes to them, and they don't control where they go. As Ms. Fox mentioned, chronic care and those sorts of things, housing are issues. And so if you look at this, the least expensive places to receive care and where to prevent the need for more advanced and expensive types and sites of care are shown at the top. Houses, homes, group homes, adequate numbers of facilities for mental health treatment of substance use disorder, and so forth are needed. Enhanced capability and staff for primary care, mental health and substance use disorders, and other things are also needed. As depicted, when these things are not readily available, people seek care in the emergency department, sometimes with an advanced form of illness needing hospitalization. If the illness is too far advanced, or if the community hospital is full, they may require transfer to a larger, distant medical center. The result is an inconvenience for both the patient and her family, together with a bigger bill for care. Using all this information, analysis, and reports from prior state commissions and consultant reports, we then constructed a financial prognosis or forecast. This makes certain assumptions which we have tested with a number of people. Not everyone agrees with the exact numbers. Shown on the left here are the increases and changes requested by Rutland Regional Medical Center and the rates approved by the Green Mountain Care Board. Over this 5-year period from 2018 to 2022, in the upper set of boxes, the hospital requested about 5.8% increase on average. The Green Mountain Care Board approved 4%. Below, in more recent times, the hospital requested about a little under 12%. The Green Mountain Care Board approved 11.5%. So on the right in that graph, to the left of the gray bar, what you see is the past performance of the hospital. Now that includes COVID and changes in volume. It includes federal and other dollars to support the hospital. And so we just note that. We chose as a base year 2003 because it was after most of that. And we made two assumptions. One is that there was a cap on rises in hospital revenue and prices of 3.5%. This is the current cap for revenue expense increases set by the Green Mountain Care Board in its effort to slow the rise in healthcare costs. Estimates of the ongoing increases in hospital expenses nationally range from 5 to almost 8%. And there's a recent estimate, I think last week, from PricewaterhouseCoopers, a different consulting group, that they expect the increase in prices next year to be 8%. But some hospital executives in Vermont told us they plan to control their cost increases to 5%. So that's the assumption we show here. We also did projections using a 7 to 8% increase in expenses and shared those with the hospital and its board. Now, you see here, no surprise, if your expenses are going up faster than your revenue, things go south in a hurry. And so assuming that no changes are made, and that's another big assumption here, and as I noted, the hospital and the leadership are working hard to make those changes. What you see is that by 2028, there is here roughly a 5% negative margin. Every hospital in the state, except one, shows these same red numbers, and the one declines down to less than 1% above waterline. So this is a universal problem. And it's a lot worse if that inflation rate for expense is 7 or 8%. Some of the hospitals in that scenario are minus 27%, which means the bank will be calling. So we've got to fix the way this is done. Hospitals are the most expensive place to get health care. They are very appropriate when you need it. There are a lot of other ways to do it. This shows the approvals for the Green Mountain Care Board. And what I want to call your attention to is the small numbers on top of these bars are in billions with a capital B. And what this shows, this is statewide, all the hospitals, so that's why it's billions. In 2013, the revenue that was approved was $2.1 billion. And in 2024, it was $3.6 billion, which is a 74% increase, average about 5% a year. And below, in those smaller numbers, you note that overall across the state, about 100% of the requests were granted. Now, that is not to say, as we showed in the previous slide, that every hospital got everything they asked for. But in some, the number is quite high. As I noted, insurers are losing money too, and I think this hit the press in your area Monday, and it hit the national press Tuesday. These are the underwriting losses that Blue Cross has suffered. And an underwriting loss is the difference between what they pay for your health care versus what your premiums bring in. So what happens when this happens is they have to draw down reserves. Now, the Office of Financial Regulation in the state and other states require them to maintain a minimum reserve, so they have the bucks to do this and pay this. Those reserves are dangerously low. I served on the board of Mass Blue for a while, and my hair would be even whiter if I were looking at these numbers. This is not good. And so what it says to you is The insurers are not making money. There's no more money coming from the insurers, right? That money is either going to have to come from higher premiums, which again are happening, and affecting school taxes and a number of other things, or it's going to have to come from the feds. And as you're aware, they are very tightly controlling funds for Medicare and for Medicaid. So what do hospitals do about this? Well, things we learn in hospital administration school and consultants teach are you've got three major levers. One is you increase the prices to the commercials because they pay the government programs, Medicare and Medicaid, underpay. Medicare typically pays about 85% of what the hospital's costs are. Medicaid typically pays around 65%. So that difference is then gotten from the commercial payers, generally. And you see that's part of what's been happening here. You can reduce operational costs, which people are working very hard on. These expenses are difficult to do in small rural hospitals because they're already minimally staffed. So you think about the emergency room in a small hospital. You have one doc, you have maybe two nurses and a couple of medical assistants, you have an on-call lab tech, an on-call radiology tech, and whether you see 5 patients or 35, you've got that staff because that's what you need to staff 24 hours a day. And it's similar in the nursing units on the inpatient side. So the ability to do cost reduction for a small hospital is very difficult. It's a little easier in a larger hospital. The third thing you can do is increase the volume of profitable services. So that's orthopedics and some other things. And as a last measure, you eliminate non-profitable services, and that generally is pediatrics and OB. The only part of pediatrics and OB that really make money is the NICU. I mean, unfortunately, that's the way it's paid. The other option is you request financial relief. You get money from the state, you find a large donor, Elon Musk shows up and gives you a couple $2 billion to support the hospital. So, as noted, hospitals can't solve these problems alone. Different and more innovative approaches are needed to reduce costs and improve health services in the community. Solving these challenges will require concerted, sustained systems transformation efforts with the Green Mountain Care Board and the Agency of Human Services. And I would note significant change. This is not fiddling around the edges. Okay. And I would also point out that the measures which have been taken over the last 20 years are producing in part the situation you're in. So you've got to relook at them. And you all need to be actively involved in that because Ms. Fox and her group and the Agency of Human Services and others will certainly be involved in that. Okay. We did, by the way, look at whether solving some of the hospital capacity and access problems could result in enough people coming back to the community for care. That is, people currently go elsewhere because they can't get in to see the doc, or they come to the emergency room, the hospital's full, and they have to go somewhere else. And so we took a look at that. And yes, if you free that up and you allow people to come back, then you make more money, but your expenses also go up. And so you gain a little. So you may go from -7% loss to -6, or from -17 to -15, but it's not a huge difference. And it really doesn't change the trajectory. Okay, so as I mentioned, hospitals can't solve these problems alone, and it really requires concerted systems transformation. So, what can healthcare in Vermont look like? What's needed? What things are already being done that can be built on or enhanced? There's a lot. What does charting a path forward look like? Well, first, the main issue is to recognize the current situation and the adverse headwinds you're facing. The Marines would term this adapt. We've discussed a lot of this a few minutes ago. Second, you change what you can and build on current efforts to change the way healthcare is delivered in your community. The Marines would call this survive. Next, you design and implement ways to improve access, improve equity, and reduce the costs of healthcare for your community. The Marines would use the term overcome for this. Done in the right way, these changes can ensure that redesigned services have both a stable financial and a stable operational future here. Abraham Lincoln said the most reliable way to predict the future is to design it. So, okay, the new system you will design will need to address both your current needs and those of your community in the near future. Shown here are the mission of Rutland Regional Medical Center and the most recent community health needs assessment, which the hospital does with you every 3 years. And you see a lot of these are the things that we just talked about: housing, mental health, child care, food insecurity, and so forth, and aging. And so these things are underway. And this slide shows in a little more detail what's going on. And as Ms. Fox said, a lot of this in cooperation, collaboration with a number of people in the community and other organizations. So affordability, they've reduced costs substantially, and they've reduced the need to request increased commercial rates. They're providing a lot of free care. They've put programs together to really help educate the next generation of healthcare professionals and allow people in the hospital to have career progression. They're doing a lot of recruitment, affiliations with different nursing schools, and offering community scholarships, teaching people basic skills, doing a lot of support for primary care, and partnerships with other places, dialysis on site with UVM, specialized HIV service, GYN oncology, and so forth, doing ED consults with Brattleboro Retreat so patients can get started on their treatment while they're waiting to perhaps have to be transferred, community collaborative, inpatient psychiatry unit, very important things. And then you see in the community needs group transportation, to assist with appointments, pharmacies, and shopping, and health trust funds to support services based on community needs. So a lot of things that can be built on to help address these problems. Changes at both a hospital and a state health system level are still required to meet both current and future needs. These fall broadly into the 5 areas shown here. One is to embed updated and modern information technology in hospitals, offices, homes, and other places where people receive care. Housing for Vermonters and others moving into the state. Some in the state have no house. Others are living in houses without water, electricity, or heat. This is arguably the most urgent need Vermont has, not only to address inequity, but also to provide a safe place for people to receive appropriate care outside the hospital. Adequate housing, whether a single dwelling, mixed income housing, group housing for those with mental health or other needs, or assisted living facilities, is required to reduce the crowding in hospital emergency rooms and the number of people staying in hospitals and mental health facilities because they have no place to go. Transportation for people to and from medical care, pharmacies and other places needs to be enhanced, and you just saw that that Rutland Regional Medical Center is working on that. The emergency medical services, which are largely staffed by volunteers, need to be combined, linked tightly to the hospitals, and made into a full-time professional workforce. This would create additional jobs in the community and allow the provision of patient transport to and between facilities using vehicles other than a mobile ICU. I want to comment on this. I've been told there are 76 different EMS services in this state. Most of them are volunteer. What we've seen in other communities around the country is that as the population ages, the number of people who are sufficiently able and willing to volunteer for EMS or fire departments drops. And there are communities around the country that have lost those services. The other issue that the hospitals face is that when somebody is brought into the hospital by an emergency transport group, an EMS service, that ambulance is not always there to take the person from the ED somewhere else. And we've heard stories from a number of emergency room physicians that they can spend first 6 hours on the phone trying to find a bed in a hospital, and then they can spend another 4 hours on the phone calling up to 30 EMS agencies to find somebody to take a patient from A to B. And so you've got a patient sitting there for 10 hours in the ED needing service, and they're not going anywhere. And what you see around the country is that increasingly these EMS services are paid a living wage, and they are not only used when the transport is needed, but they can do services in the community. They can visit people in the home. They can check blood pressures. You know, they've been given vaccines during COVID. And, you know, they're educated folk. They don't do all the things a nurse does, but they're a significant resource. So that's one of the things that we want to encourage you to think about. So in the planning process that that has been mentioned, hospitals and communities will need to design a system in which there could be regional referral centers, each containing an area with a sufficient population to support the physicians, staff, equipment, and other services needed to provide high-quality, efficient care for specific diseases or conditions. Work we have done and shared with each hospital suggests there is and will be sufficient need that some of these centers could be supported without people having to travel the distances to UVM, Dartmouth, Albany, or Boston. You're fortunate in this community that you have a large enough hospital to do a lot of this. Other communities are not that fortunate. In the system to be developed, all providers primary care people, specialists, dentists, EMT, hospitals, social care providers, and others should have their payments linked to common goals, access, quality, efficiency, appropriate use of resources, and equity. Let me be clear about efficiency. This means doing the right thing at the right time, not forgetting to give a vaccine or ordering a more expensive test when another would be adequate and less expensive. As noted in the green below, the goal is to provide the most appropriate and needed care in your home, in the community, or close by. So there are a lot of options. Some of these, as you've seen, Rutland Regional Medical Center has underway. A number of these are in development. I've presented a more complete list to the Green Mountain Care Board, although that's not exhaustive. There'll be more in a final report. I would emphasize that every one of these things is being done in the U.S. So it's not rocket science. Some of it was developed from that because of the moonshot and all that. Increased use of telehealth, for example, and you have examples here. Increased use for remote monitoring and patient follow-up. So think about this. You can monitor your arterial oxygen and your heart rate on this thing. I can tell you when I trained, the only way to get a blood oxygen was you drew a blood sample from the artery, you sent it to the lab, and an hour later you knew what the oxygen level was and whether to turn the oxygen supply up or down, what to do with the respirator. Now, you do this in real time. And so the capability is there, literally, for a number of things to, appropriately chosen and all that, to send a person from the emergency room on treatment home to be monitored. And there are, a lot of things that have to be done. It's not straightforward, but it's being done elsewhere. Rural outreach programs for taking primary care and preventive services, whether that's something like a mammogram or screening for osteoporosis, out into the community. A lot of the primary care groups and urgent care centers have expanded hours and then have had to retrench because of nursing shortages. We talked about emergency medicine. The Agency of Human Services currently has an active program to tell who has mental health beds available. There was a similar program during COVID for acute care beds that ended in May. And if something like that could be recreated, then the emergency room folk would not have to call 19 hospitals to find a bed. So it would speed things up. Regional service lines we've talked about with hospitals cooperating. There are a group of hospitals that have recently come together to form a combined contracting agency, if you will, for insurance and supplies and so forth. Hospitals around the country have done that in similar ways. The state of Indiana, for example, recently came together and they have a nursing float pool that can fill in nights and weekends and when somebody else needs help. Established programs targeted at high needs groups. There's only one of these that I'm aware of in the state, and that's SASH. There is a group of people in the state, currently about 31,000 and some, who are called dual eligibles. They are people with sufficient complex illness, both mental health, physical needs, other things, that they get medical care paid for by both Medicare and Medicaid. That's why they're dual eligible. That group nationally accounts for 30% of all Medicare dollars spent, and it accounts for 32% of all Medicaid dollars spent. So it's a fantastic group expensive group. They represent only about 14% of all Medicare beneficiaries, for example. So it's a group that if you address and you give them good care and you are proactive, that you can reduce the expense of their care. And if you connect the dots, that reduces the losses in the hospital, and that reduces the need for commercial premiums. So this is a group that I think represents real opportunity to not only provide more equitable care, but also better care. But it will need to be developed, and there are programs that address part of this. Okay. So these are the major steps in designing the future for healthcare in your community and at the hospital. The first step in green is to make the decision to change. I hope this presentation and the other information has convinced you of this need and its urgency. In this process, you and many others can choose among the many options we will present in our final report and construct some of your own. These options will then need to be examined for their impact on the community and their financial stability. Planning sessions and budgets to support the final options and plans will need to be made, and the plans implemented. The Agency of Human Services and its many components have numerous services available and are at various levels in testing and implementing others. Many, but not all, are listed here. Time does not permit an exhaustive review, and this slide and others will be available on the Green Mountain Care Board's website. I would call your attention to the major efforts directed to mental health and substance use support and to elderly care support. Major efforts are also underway to improve the infrastructure for transmitted medical data and to streamline the processes needed to get new healthcare professionals into Vermont. The Green Mountain Care Board has also had a number of efforts underway to try to constrain the increases in both medical costs and insurance premiums. These are shown here, and I would note that a long time ago they commissioned a Rural Health Services Task Force to recommend ways for improvement. Some of those things have been underway, others are included in our recommendations. The Act 167 effort that we're engaged in and you will be continuing in is another result of that combined effort of the Green Mountain Care Board and the agency. So where do you go? How can you get involved? You can attend community meetings and planning sessions, monitor the websites of the Green Mountain Care Board and the relevant units of the Agency for Human Services for updates and opportunities to comment and provide feedback on their plans and activities. You can support the administrators of the hospital and its board in making what may be difficult or painful choices. You can speak with your legislators and the appropriate state agencies to express the need for making the laws and funding available needed to put your changes in place. Change will not happen by itself. Designing and implementing an improved sustainable health delivery system for Rutland and other communities will require the active participation and engagement of everyone in this room, of other communities and hospitals, and of the state of Vermont. As shown by this photo of an Amish community raising a barn in Lancaster County, working together, much can be accomplished. You have many more tools available to you than the farmers in this picture. This is all hand work. So you have a lot more to work with. Broad changes in custom and practice are also required across the state. What affects one community affects many others. an unplanned, unanticipated disaster in one community, whether it's a flood, a pandemic, or an unanticipated hospital closing, has impacts throughout Vermont. As I discussed a short time ago, the financial projections for many hospitals in the state show diminishing financial stability over the next 3 to 5 years. Therefore, your time horizon or runway to design and to begin to implement the needed changes is short. The airplane runway on the left is 2 miles long, 10,000 feet. The runway on the right is on the top of a mountain in Bhutan and is 900 feet long, with a cliff at one end and an airplane hangar at the other. I've been to that mountain. I did not fly in. Okay, there are only 8 pilots in the world qualified to fly into that airport, and that's only when the weather's clear. Now, your runway is longer than 900 feet, okay, but it's not 10,000 feet. And I'll illustrate with a story. I live in a small town in Massachusetts, about 3,000 people. My town debated for 5 years about whether to allow fiber optic cable to come to town. Wasn't going to cost town much, right? 5 years. You don't have 5 years. Okay, so the process is kicked off. The Secretary of the Agency of Human Services, Secretary Samuelson, had a meeting with the hospital folk a couple weeks ago now. And the plans are going on, and it'll be kicking off shortly. Our final report, based on the comments you and others will make after this and questions, is due in the fall. And we'll present that when the Green Mountain Care Board tells us to. And then I'm sure the process will have started before that. But so I thank you for your attention. I'm sorry we went so long. I'll turn it over to Ms. Fox for a few minutes, and then we'll take questions and comments. Sorry, Ms. Fox.
So I will be quick so that we can get to all of your questions. But I felt it was important to try to connect what Dr. Hammery described to us today with where Rutland Regional Medical Center is headed. And I want to start by calling attention to some of the people in the room. Healthcare is not for the faint of heart. And we have a number of individuals here who are representing our community, trying to make change in healthcare. I see in the room board members, physicians, advanced practice providers, hospital leadership, close community providers, hospital staff. It takes all of us. Healthcare is a team sport. And together, what I'd like to, what we've come to realize and commit to, I'd like to tie to what Dr. Hammery said, in that in his transformation slide, the first step was deciding to change. Rutland Regional Medical Center has decided to change. He also talked about designing healthcare. We can't design healthcare for the entire state of Vermont, but we can certainly design healthcare for aspects of care that we provide here. The way that we have elected to do that, our design, our roadmap, is a strategic plan. And we have invested well over a year of time on a strategic plan that is our roadmap to change and transformation. That strategic plan has 5 different strategies around employer of choice, access to care, quality, financial stewardship, and transformation. These strategies are not mutually exclusive. They're integrated, and we need them to work together, and we need to have success in each one of these strategies. If we start with our employer of choice, if we don't have people, we can't provide access. We can't provide access for the sake of providing access if we don't think we can do it well and with high quality. And we've got to make sure that we're financially resilient. So we have to make good choices. And under all of that is a foundation of transformation. I'd like to give a few examples within each of these strategies of why it's important. I could talk for days, but I'll try to keep it short. So, employer of choice. We're looking for 160 employees. Now, we've had some success. At our most dire situation, we had about 200 people we were looking for. And so things like housing, daycare, are pieces of work that we're considering, trying to decide what play does Rutland Regional Medical Center have. Just yesterday, got word from our HR department, we had offered a position to a diagnostic imaging technician. They accepted the offer and then turned us down because they couldn't find housing. These are real stories. In terms of the levers that Dr. Hammery talked about, those are the levers we pull, and I'd like to tell you where we are with each one of those levers. On the lever of rates, you can see that we have had a significant rate increase a couple of years ago. Prior to that, we were below the hospital median. We know that that can't happen, and so we have been very committed to keeping our rates low. Our rates going into our 2025 budget are within what the Green Mountain Care Board has set as a requirement and are right around 3%. Our cost savings, second lever. Over the last 2 years, we have been very committed to looking at costs. We've cut costs by more than $8 million, which if you're a payer or an insurer, what that impact is, Rutland didn't ask for 6% of rate increase because we took care of it ourselves by way of cost reductions. Now, we're not going to solve our problems by cutting costs. We'll die on the vine. And here's why. If you look at our cost report, so this is an annual report that we file with the federal government that looks at all of the costs for the care that we provide and compares it to the reimbursement that we receive. Last year, our last cost report that we just submitted in February, if you look at the amount of costs to care for our Medicare and our Medicaid population, and you compare that to the reimbursement, we lost $39 million. Now, if you look at the slide that Dr. Hammery presented on our operating margin, and you look over 5 years, Rutland Regional Medical Center is a break-even organization. If you take the minimal gains, we had a significant loss, we came back up. If you add those up, we're break-even. That doesn't take into account inflation, where we need to replace an MRI, that's $4 million. We want to invest in a PET CT, $3 million. We need to replace our linear accelerator. It's going out of service. We have a huge plant to take care of. And so cost reductions are really important, but we won't do it alone. And so that's where transformation comes in. Rutland Regional Medical Center did provide the Green Mountain Care Board and the Agency of Human Services a letter of support to consider the AHEAD model. We did that not because we think AHEAD is the right thing to do. We don't know. Where our position and our dedication to that letter of support was, we have to at least give it a try. And if you look at Vermont healthcare spend, and you look at where we are and compare our spend to the median spend of other states in the nation, if we were to meet that median spend, Vermont would get about $325 million more each year in reimbursement. That's what we're going after. We don't know if AHEAD is right. We're going to partner with Green Mountain Care Board, with AHS, to try to make a good decision, but we at least have to try, because that $39 million loss that we're facing, we're not going to make up for it in cost reductions. We can't put more pressure on our commercial insurers. Tons of things that we are doing. We've got 12 strategies. We're fully engaged. I'm happy to talk with any of you about those. Anyone looking for our strategic plan, happy to provide that. But did want to try to cross-reference what Dr. Hammery is saying with what this leadership team is doing and committed to for our community. In closing, I'd like to thank our community. I see our delegation who works hard for us in Montpelier. I see lots of community members, community partners. Thank you for being here with us this evening. Your support is really important. It's going to take all of us to move forward. So thank you.
Thank you very much. So questions, comments, happy to take questions. We'll have some roving mics. Yes, sir. He's coming.
Hi, I'm Frank Nelson, and I have a little Asperger's, so I tend to go down holes, compulsive. My mother at one time said there's pills for people like you.
Okay.
But I've been studying these numbers. And
Would you hold that?
I've been
close?
looking at
Thank
these
you.
at the numbers for a long time, being in the financial services industry, where we would examine the health of insurance companies across the board, and that's the trickle down. That's where the bills were paid. And exploring annual reports and stuff from the Society of Actuaries, and these companies, these insurance companies, since COVID started, was a big. I wanted to see what was going on with all the numbers, and I went to Department of Financial Service Financial Regulation of the state of Vermont, and had to get some assistance to try and get numbers out of the insurance companies, and built a trend of about 2 years or 3, and they weren't trending in a positive direction relative to overall costs then either. It was a step up maybe in costs from before. And so I was, again, I could go on for 2 semesters on this, but I'm trying to cut it down, is that you have the Society of Actuaries surveys involving surveys of 80% of the insurance companies in the country, and what's happening in snapshots in their reports. And then you have in the healthcare area, you have not only the area you're talking about here, the immediate hospital environment, but you're talking about somebody who's gone into a hospital who is also very oftentimes experiencing a disability problem afterwards, which is very costly, or death, which is a finality, but there's a cost factor in that to the insurance companies in particular. So what's going on is that we have a cause and effect scenario, which this little snapshot is a part of due to cause, which everybody says, what causes cancer, blah, blah, it goes that part. And then the cause would be what causes cancer, what causes people to arrive at the institution. And so, and then you have the effect, which this scenario is a part of the effect. It's the overall cost. I'm going to cut it short here. But in the area of reinsurance, and I've been reading some reports.
We're not interested in reinsurance. I apologize, but the question is what?
The question becomes, you're looking at mean figures, and given the potential for inflation and and some other cost factors, which some are predicting due to the numbers, if they don't trend down, then what is Plan B after Plan A when you're looking at these potential increasing costs, which some of the reinsurance writers, people writing articles about, are saying this is going up and they're getting out of it potentially. So is there a Plan B if things get worse?
Well, the Plan B is to reduce the cost of health care to you and the insurers. And there are a number of ways to do that. Now, what happens if that doesn't work is 9 out of 14 hospitals close and there's no care, right? So the process is going to have to work. I mean, that's the way that you get care and where you get care will change. They're changing around the country. I mean, the issue, I think, really comes down to, again, although they're well-run, and they're run by people who know what they're doing, hospitals are expensive places to get care. And just to give you an example, you know, if you have a patient who doesn't have a place to go, and they're being taken care of in the hospital, a consultant about 4 years ago estimated that would cost $900 a day for the hospital, to meal, nursing care, all that. It's considerably more than that now. I called the Ritz-Carlton in Boston on the day after the 4th of July. A bed in the Ritz-Carlton cost $635. It's not to say the hospital should charge that much. What it's to say is that it's just an expensive place to get care if you don't need to be there. So plan A and B are really a variant. You have a couple of different ways to deal with that, right? And I think it's important to note that overall, you know, people look at the country and they say, well, the insurance companies make a lot of money. And that's true, but not in Vermont, right? You don't have United Healthcare here, or a lot of Aetna, or those folks that are, you're reporting, you know, I don't know, $15 billion of profit in a quarter. Those are not in Vermont. So I appreciate the comment, sir. Thank you. Yes, sir. Or we have somebody over here. I'm sorry. Yes, ma'am. Yes, sir.
Mark Miller, I'm from Mount Holly. I didn't know what to expect today. First of all, thank you for pointing out that I'm supposed to go to the doctor 11 times a year, but I haven't. About 45 years ago, I was told I'd be dead in 2 years. That didn't work out too well.
That's
for
great.
me. I'm suing my doctor for malpractice. He's still my doctor today. But I didn't know what to expect. What I came here for today was because, fortunately, in the same age group, my first interaction, I've had a couple of interactions with the hospital that have been fantastic. I will hand it to them. It was awesome. About a year and a half ago, I had a specific emergency, and the reason I came today is because what I'm wrestling with after the agony of the last year and a half and horrific medical care in Vermont, I had to end up going to New York to have it taken care of, is I'm trying to decide, is Vermont the right place to get older? As much as I hate to admit it, I am getting older. I can't stop that. And I am incredibly frightened about the fact that living in Mount Holly, which, by the way, is one of the towns that just lost its ambulance service, my experience with a specialist in the Rutland Regional Medical Center community, I have a real concern about getting old in this state. And we are the first, second oldest state in the country as it is.
Correct.
I own businesses. I understand everything you said about the money. I get that you can't operate at a loss. Believe me, my brother doesn't get it, and I operate at a loss. That's where we are. Where are we going? Where am I going to be in 2 years when I need a doctor again? Hopefully it's not going to be 11 times. But I see fantastic plans, but they don't help me as somebody in his mid-60s. So it's not really a question. It's just you sort of answered my question that I came here for the information on. Is Vermont a place to get old? And I don't think it is. Thanks.
Okay. Thank you for the comment. Appreciate it. Sir.
2 points. You had a chart up there that was showing the various community resources that assisted healthcare in this area. You didn't have anything about the community healthcare network, CHCRR, and which is substantially reduces the burden on the emergency room and other resources in this hospital. Yes. And that's a partnership that needs to be expanded. The other thing is you had a chart that showed a demographic disaster for Vermont.
Yep.
New Hampshire faces a similar future. But there is a solution, and that's more people. And the people that are going to come here, if they're going to come here, aren't going to look like the people in this room. And it's very important that Vermont and then down to this hospital and this community make this a more welcoming place for diverse people. and that will help expand the population here. Burlington has already done that, and it's happening here. There are refugee resettlement groups here.
Yes.
There's the local Chamber of Commerce, Cedar, has a program to bring new people here, and they brought about 800 new people in the past year or so. So the future isn't as bleak, but it's important that this institution and the employer community work together to bring more people here. And of course, they need housing to do that.
No, thank you very much for those comments. I think, just to add to that, being able to address all the needs of the immigrant community, language, ethnic sensitivity. For example, Islamic women should not be examined by a male physician. Just a rule. So those sorts of issues also weigh in. But no, you're exactly right. And one of the things that we've got on our list and have been talking to people about is that a number of the immigrant or let's say communities that are coming in from foreign countries have healthcare professionals who are well trained, many of whom speak English, and could be used if licensure and other regulations were modified, and other states are doing that. And so that can be an additional way to also add resource to the community. But no, you're exactly right, and please remember, all that is an unaltered future. So it's not written in stone, right? One of the reasons that the things your community's doing, and the hospital, and AHS and others, and that's one of the reasons, as was said, there's opportunity here. And there is a chance to reshape the future and make it something different. But thank you for the comments. Yes, ma'am.
I'm Sue Blish. I've been a hospitalist in this hospital for 23 years now. And I would like to make a comment that dovetails a little bit on what you said. Over that 23 years, I have seen it become more and more difficult for our older population, which we all know is burgeoning, to find viable options for long-term care. People can't live independently anymore. People need to transition to some sort of supervised living arrangement.
Right.
I have seen it become more and more difficult for people to find that, and their families are struggling with how to take care of them as well. I am concerned, we only just touched on it a little bit here today, with the access to long-term care facilities. We have seen a lot of local facilities close here, particularly community care homes.
Yes.
Community care homes and other less structured options can be a very cost-effective alternative to the traditional skilled nursing facility and provide care that is, as we like to say, appropriate care in an appropriate place in a cost-effective
Yes.
way. As I've said, a lot of places have closed. I am not seeing a lot of people rushing to fill that void in Vermont. I don't know why. I know there are people out there that love taking care of older people, so why are they not rushing to do this business in Vermont where we have such a large and burgeoning need? So I am begging our state legislators and our and our Green Mountain Care Board to do whatever you can, whatever is in your power, to create a landscape for this kind of care that is nurturing economically, socially, and legislatively, to whatever power you can, to nurture this community. And I think a little more of a bottom-up problem-solving approach might be a wonderful thing, as opposed to a top-down regulatory approach, taking with these people, nurture them, help them to grow, help them to feel you're on their side instead of on their case.
Thank you very much. Other comments or questions, please? Oh, yes, ma'am.
Hello, my name is Kaya Ganguly, and I'm going to riff off of what you said, which is, if you look around, I'm probably the only visible person of color in this room.
Mm-hmm.
And until we become leaders in making Vermont an equitable place, I guarantee things are not going to change. because as fast as we recruit people who belong to an underserved group, we lose them and they leave because it is so unwelcoming. I have been in Vermont for most of my adult life. I came here in 1985. I left to go to grad school, and then I came back as fast as I could. I've raised my children here. My children serve this community. A lot of you know them. But they still walk down the street and get told, go back to where you come from, you Arabic C word, in spite of what they're doing. So if you truly want health equity, you need to start looking at these groups. You need to start digging into our demographics. For example, the latest Youth Behavior Risk Survey says that 20% of our youth identify as queer. What are we doing for them? If we truly want Rutland to thrive, we need to retain our youth and increase, because that's one effective way to help. But I don't see a heck of a lot happening. Same thing goes for BIPOC folk, even though I hate that acronym. When you look at our youth and you dig down, about 18% of them identify as multi-ethnic, Black, Indigenous, and we're not doing a lot for them because, oh, we're only 6% other. We need to stop losing these people. Thanks.
No, thank you for the comments. I think one of the things we heard from someone, just it's a simple example, and not as poignantly or expressed as yours, is we spoke with a woman who is African American, and she said that she had to leave the state to get her hair done. Right? So, no, it is, and I think, one of the issues which the legislature's tried to help is the language, but and a number of the hospitals are doing ethnic sensitivity and, how to speak how to understand the issues of people with mental health and other things, but those need tremendous acceleration.
Well, that's my field, so I get what you feel. I live that.
Okay.
Not personally, but professionally.
Okay, thank you. Other comments or questions? Yes, ma'am. Ooh.
I probably don't need that. I have a big booming voice. I'm Paula, and I represent. Sorry. Say that.
No, we got to hear you. My hearing aids turned all the way up, and I need to hear you. Thank you.
I represent elder care in the Rutland region, primarily dementia care of our elderly. And we've been doing it for 23 years, my husband and I, and we built our care homes based on our own personal experience. We had other lives before, so this is our second go-round with a job. I'm very concerned about the future of elder care here in Vermont, especially. There is a huge push on pushing through new regulations that will impact both residential care and assisted living facilities, and it will, you can judge for yourself, but it will put us out of business. And that is not, I'm not being a drama queen, it is reality. And I spoke up here. I'm always the black sheep in the world that I live in. I'm very proud of what we do. And I appreciate Dr. Blish for supporting us, and all of these folks that are here with us today. I'm very proud to have them here, and I think that partnering with the community is a wonderful way to do this. So I'm willing to do that.
Could we speak after this? I'd like to learn a little more about that.
Sure, sure.
Thank you.
Thank
Please, yes, Judy.
I want to be very clear with where we are as an organization. If you look at the number of patients in beds upstairs and look over an annual, basis, 8 to 10% of the individuals upstairs don't need to be here. They do not have a medical need to have care here. They have no place to go. And so they do reside here. As Dr. Hammery suggested, we don't get paid for them because there's not a medical need. And oftentimes they're in a bed that somebody who has an acute medical illness waiting in our ED is waiting for that bed. And so we have worked very diligently with our primary care partners, our home health partners, our mental health partners, even within our utilization management and our physician teams here, trying to get placement for some of these individuals. I know AHS is working on opening up a site in Bennington. My fear is it will relieve some pressure for a bit of time. It will fill up and it will be non-recognizable again. So I just want to make those comments that we understand, we feel your concern, we live it every day, and are in an open dialogue with anybody who will listen around how we can take care of this population a little better.
Thank you. Other comments or questions? You've been a very attentive group and hanging in there for a long. I'm sorry, we have somebody else. I didn't see you. Sorry,
I just
sir.
had a question about one of your slides, one of your early slides that showed the increase in insurance premiums and a comparison between Vermont and Massachusetts. And I understand that the demographics of our two states are different, but it was pretty striking as to how the insurance premiums went up so much in Vermont and basically stayed flat in Massachusetts, because the demographics were probably about the same at the starting point as they are now. So that couldn't explain much of that difference. So I'm just curious what you think Massachusetts is doing differently, because either their hospitals aren't getting paid and their providers aren't getting paid, or they're not providing care, or they're doing it with more efficiently.
They're having the same problem. My wife works at the BI, and in fact, Mass Blue, the foundation, is trying to look at what the need for nursing homes, long-term care, all that is, because they're a little behind you. Okay, the percent of population that are elderly is lower right now. It's going to age. I mean, it's all the baby boomers, right? And so I think part of it is that. Part of it is it's a much larger state, and so they can spread the cost out over 7 million people as opposed to 640,000. But they are experiencing the shortages and the difficulty in getting people out of the hospital. There are similar, not quite as extreme an issue with the cost of housing, okay? Because if you're in metropolitan Boston, yes, it's very expensive. If you move 50 miles out, it's much less so, and the rate of rise in housing costs has been a little slower. So it's headed the same way, but it is a different set of total circumstances. But again, the hospitals are still have borders, still have problems getting people, and still, nursing homes in short supply, home health agencies competing with much higher payments in hospitals for nursing staff and others. Other comments, questions? Sir, yeah, we've got two. Uh-oh, we're having a race.
Oh.
Sir, yes.
Hi there. Hi, I'm David Schneider. I'm a physician, practiced pediatrics for 32 years in Rutland, and have been attending a number of these meetings. One thing, first of all, I just wanted to comment on your comment about hair care leaving the state. A number of years ago, I actually went back to school, as all physicians just love to go to school, for a degree in healthcare transformation. And we spent about an hour deciding whether hair care was considered healthcare. And many of us took the point of view that it absolutely was, that in terms of self-care, in terms of self-esteem, in terms of just feeling good. So you just made me think of that. So that was a really cool thing. One comment that Judy Fox made about transformation occurring here locally in our community, because we really, the state might just, I don't want to paraphrase you incorrectly, Judy, but that we can't really worry about the state. We have to really more worry about Rutland. I do disagree with that. Rutland is in with the state. We are absolutely, all the payment comes by way of the country, frankly. So we can't, any real transformation has to be on a global scale ultimately. We can lead the way, I think, certainly, but so much of this is going to be state dependent in terms of how things are funded, where the money comes from. And as you pointed out, Vermont only allows nonprofit insurers. But we are dependent upon insurers for payment. I attended one of the information sessions and a few weeks ago, and there's something like $6.4 billion in Vermont healthcare. So the money is here. And you know, it's just being shuffled around the wrong way, I guess. And obviously there's a tremendous amount of waste. And I wonder where we are with Act 48 from 2011 that actually founded that was the start of the Green Mountain Care Board, where we were talking about the statewide universal health care, at least a universal primary care, where it's eliminating commercial insurers, at least directly. Mm-hmm. And, you know, where are we with conversations about that? When we're talking about transformation, I mean, transformation means what we see now is what we have now is nothing like we're going to be seeing in the future. And that's the only way we can survive. And to do that, we have to look at different payment models altogether rather than shuffling around the edges, as you put it.
Right. So, yeah, I think, you know, I can't comment on the past, right, because I wasn't here and you were. But I think this is one of those areas which y'all have to relook at. Okay, your point about having to do, about needing support and change at a state level is on point. And from where I'm sitting, the promise of an all-payer model is not met, right? You have Medicaid in it, you have a little bit of Medicare, and not a lot of commercial, about 60%, I think, but there's 40% that's not there. And when I look at the hospital budgets, there's a lot of fee-for-service Medicare as well. So it's not really an all-payer model. And it doesn't function that way, right? The systems that are set up to distribute the money and to identify people in need of additional services are rudimentary.
We're also dealing with layers and layers and layers of administration.
Yes. And to your comment, the state budget total all in for healthcare in 2020 was $6.4 billion. I don't know what it is today. But if you just presume, and that it is an assumption, that there's 10% in there that could be reallocated, that's $640 million. You can do a lot with that. So I think part of this effort, which the agency has taken on, and the Green Mountain Care Board will certainly help with, is to help identify where there are programs that have not been as well executed on or done as they could be, and whether there are programs that would work better together. Are there ways to reduce forms and all that? And there are programs that are looking at that. different ways to deliver care. Hospitals currently account for, I think, 35% of the total spend. Maybe more, but it's a significant part compared to primary care and some of the preventive services. So I think your point is right on, and I think that's a task for you all. I think, Ms. Fox has pointed out appropriately, some of this has to be done community by community. I mean, you've got to decide with her and others and the agency what services are most in need for you, for your community, what's the most efficient way to get those done, and the most effective way. There is a larger state component, right? If you've got some other hospitals around the state which will be in much worse financial shape in the next 3 years, and something happens to them, those people need a place to go get care, right? So that to me is part of the planning process, because as I mentioned, in aggregate, if you took all the unaltered losses from all 14 hospitals in 2028, and how many millions of dollars that'll take, it's close to $500 million. Okay, so you've got that much stuff that has to get changed, right? But there are ways to do that. And you've got a group here that's helping lead that charge. Okay, and so it's possible to do, and it needs to be started. It won't be complete, right? Process will probably never get complete, but you can get a pretty good start on it, right? And addressing the manpower, the personnel needs, the workforce needs, and the housing, and the transportation, and the economic development that's going on in the community, all offer ways to do that. Okay, they're going to take a little time, and so some of the things that are not yet being done or that are very early in the process may need to be speeded up, and some of that you'll have to do by making other decisions about what happens. Okay, but that's within your collective capability to do, and you've got people here who are working in these areas that can provide you real time. Here's what the practical issue is, right? Here's what we've got to solve for. It's not a theory. I'm an operating guy, not a policy guy. Okay, so it really gets down to some of the things that were said earlier about bottom up, right? The folks that live the problem, work to solve the problem, and what are the barriers to that, right? And so, like any good leader, you say, what are the barriers? What do I need to fix?
So if I could, I fear maybe I wasn't clear, so I'm going to take another shot at it. When I say that there are issues that Rutland can't solve, it doesn't mean I don't think Rutland is part of the resolution. We have to be very clear and realistic about what we can get done within our organization.
Right.
And we have to be very, very committed. It's hard work, hard decisions. And that's where we are as a leadership team. But we're also very engaged, and I think if you look and ask our state partners, whether it's AHS, the Green Mountain Care Board, VAS, we are very engaged in state efforts, as is demonstrated by our willingness to be courageous and put forth a letter of support for the AHEAD model. That wasn't, not all hospitals thought that was a great idea. And so while we can't control it, we have not buried our head in the sand, and we're very engaged in any dialogue. And as I say, if we're not invited to the table, we'll try to elbow in because it's really important to us. So sorry if I wasn't clear.
Okay, thanks. I just personally, I am really terrified that there's an enticement of money with an unknown of what the money is for.
So I will not stand here and say, I think the AHEAD model is great and we should go for it. We've got a year of negotiations that we're putting our faith in the Green Mountain Care Board and AHS in helping to negotiate. I hope they listen to us. We're going to be behind the door offering lots of guidance. We don't know if it's the right thing, but as Vermonters, if there is money to be given to the Vermont healthcare system through this modeling, we at least need to try to investigate it to see.
And I do admire how you went right in and said, you know, we're here to at least listen and see what it's about. I'm just letting you know, somebody who I know,
Yeah.
I'm really nervous about.
We are too.
I think it's going to be more and more layers and layers and layers of money.
Let's take two more, I'm sorry, I apologize. Go ahead. No, let's take two more questions or comments, please.
Just a comment. I'm Terry, and I live in Pulteney, and I was born in Rutland Hospital, but that was before this place was built.
Yeah.
So in Pulteney, and Fairhaven, and Castleton, we had 3 nursing homes, and they were filled with my relatives because the family couldn't take care of them anymore, and they went out of business. And they went out of business because there were too many regulations. A wise man once said, if it's predictable, it's preventable. I knew in the 2010 census that we had an aging population and that we needed to do something about it, and it appears that we didn't. So in the legislature this year, we had a bill introduced called the Community Nursing Program, and it's in Brattleboro. And the community is doing it. I think that what they're trying to do is relieve the pressure on facilities like Rutland Regional Medical Center with retired nurses and doctors and dentists and just people that volunteer to help get transportation for people that can't get it,
Right.
and for providing meals for those that are in need of food security.
Yeah.
I think it's a great idea. They only were asking for $22,000 as a test program, and we didn't give it to them. That bill can come back again next legislative biennium, and I think it should. But I think we need to go back and look to the communities for what's inside there,
Right.
to step up and help take the pressure off the Rutland regional medical centers until we can figure out where we're going to go. And because we're not going ahead, we're really at a stalemate. So, thank you.
Thank you, sir. Appreciate it. Another comment, question? Sir?
I just wanted to echo some of the things that have been said about regulation. Your presentation didn't do anything about it. You didn't deal with it, and I got to believe the regulations.
Like I said, there are a lot of other things in there, and there are regulations.
Boy, but regulation can kill you. I think that people have said it killed some private homes here, and that needs to be looked at. You know, I remember when I was a kid, I went to my doctor's office. The doctor was all alone. Now you have 40 people in the office to do all the paperwork for the doctor. This stuff is crazy.
Yeah.
This has got to be stopped.
Yeah.
So anyway, that's my 2 cents worth.
Well, thank you. Those are in the list, some of them. That's why I need to talk to this lady to understand more about some of it. But listen, thank you all very much. Please remember, this is all at the Green Mountain Care Board's website. There is a comment section there. We read those comments, and if you can be specific and help us, that helps even more. So where we go from here is we have 2 more sessions, one up in St. Johnsbury and then a statewide sort of session Monday night, which if you have a friend or family member who wasn't able to come, they can sign into that and we'll go through some of the same things. But please, if you have other thoughts, if something occurs to you over the weekend or tomorrow morning, please log in and let us know. because we're putting all this together in the final set of recommendations, and there are a lot of them, and we will do this at a local hospital level, community level. We'll do it at a state level. We'll do it for some of the legislative things that may need to be done for enabling some of this, and we'll do it at a federal level. Now, heaven knows what will happen at the federal level. But you've got a very active congressional group, and they're certainly pushing things for change, and so we'll see. But I mean, the point is that there's a lot here. There are a lot of opportunities to do things differently, and you'll have, I think, a good group leading the charge. You've certainly got very good and very involved local leadership. Okay, and you're in many ways, as a community, you're blessed in that regard. So thank you again. Have a good evening. I hope it isn't raining out there. I brought an umbrella, but thank you.